with this list of differential diagnosis. طيب, what is against conjunctivitis? And it is not generalized, it is localized. Unlikely the conjunctivitis will present like this.
Exactly.
So it is now we are left with episcleritis ولا scleritis. Excellent. So now with the episcleritis or scleritis, we need to know, usually the visual acuity will be normal, and this is one you need to differentiate. Usually the AC reaction will be none, إذا كانت يعني in this context إذا كان ما هو deep one or severe one with necrotizing. Macula will be normal, optic nerve is normal, other examination is normal. This is how they usually present. أحيانا they present to you with recurrence. Sometimes you will be lucky to get them as a first occasion. Then, so we are dealing with these two entities, اللي هي either episcleritis or scleritis, which is the title of our lecture today. How would you furtherly clarifying which one and which other one? Is it episcleritis or episcleritis?
Okay, starting with the history first.
Okay, excellent.
I will elaborate more about the pain. When did it started? And for how long? The characteristics of the pain itself, radiating,
okay.
localized.
We will answer this. بس بفرصة. Let me خلي أنا patient. There is no discharge, and this pain is mild. It's not severe, and the patient is saying that he has no other problem or other than skin changes that he's having. He's saying, I'm following with the dermatology. Sometimes they're giving me cream, sometimes they're giving me tablet, but he's having a skin lesions that is recurrent. Otherwise, he is normal. He didn't complain out of this eye in the similar presentation or other presentation before. It's the first time he come to an ophthalmologist. Okay. So these are the history. Anything that you want to ask about in the history?
About the severity of the pain.
Okay. We said the severe pain is mild.
Okay. This is the first time for him to have this, or recurrent. And the skin manifestation did start.
He's saying for the last 2 years he's having the scaly changes in the dorsal part of his skin.
It's diagnosed.
Yeah. And we don't have the diagnosis yet, but he said, I have the treatment. Okay. طيب, other thing? طيب, by the way, being a male, is it something supporting our diagnosis as scleritis or episcleritis, ولا against?
Actually, in the literature, it's against.
Yeah, so mostly it is a female disease. طبعا دائما خذوها in general. Most of the immune-related diseases are common in female more than male. طبعا نتكلم عن common, it's not that يعني مثلا 90% and 10%, it is يعني 2/3 to 1/3, يعني 60 to 40, 60 female and 40 male. So these are things. طبعا by the way, when we are discussing these cases, what I am saying to you is the one in the slides that we skipped. And there was a slides about demographic of episcleritis, scleritis. ويمكن when I reach that stage you are sleeping already. فخلنا يعني more active in saying this, but take a note of these things. It is important. When I am stressing on certain point مع الدكتور, or he's stressing on certain point, these are important things that is a take home messages that we are dealing with a disease that is more in female. The pain need to be elaborated more, and the history need to be full. It's not ocular history alone, also systemic history in these cases. Okay. طيب. Let's now go to the emphasis. By the way, do we know the pathophysiology of scleritis and episcleritis? We said it is immune-related disease. Anything other than that? Why it is common in certain type of patients? Any thoughts, Dr. Abdurrahman? Okay. Okay. So there is an association between some of each. Also, there is association with some entities of vasculitis. Okay. Excellent. So there is necrosis, vasculitis, immune-related chemotactic things, changes coming to the, but exact causes we don't know. But all these are theories. If you know the pathophysiology of a certain disease, you can link its presentation with that. يعني let's say if there is يعني necrosis, it is secondary to the vasculitis or the necrosis that you are having. The blood vessel will be closed and then you will have necrosis and melting. Or there is activation of collagenases or the chemotactic factors that attacking certain body or certain part of your eye or a part of the body that will cause inflammation inside. So that will explain for you the presentation and will explain for you the treatment when you are treating these things. Okay? طيب. Now we are going to the investigations. How would you investigate such patient?
But before investigation, I would like to examine the patient from A to Z. I mean,
Okay.
examination.
Okay.
Yeah. I would assess first the injection level. Is it conjunctiva or below the conjunctiva? And I will look for any violaceous hue on sunlight.
Okay.
And
So, doctor is saying, we'll see where is that redness. We said it is localized, it is not diffuse. Sometimes you will have diffuse sort of inflammation inside the whole eye. But this one is localized. So you will say, where is the level? Sometimes with the slit test, you can differentiate. And I will show you some pictures now. Where is the exact or the approximate place of inflammation? We know the conjunctiva and the episclera and the sclera. This tiny space, sometimes we'll be lucky to differentiate where is the inflammation with our naked eyes, with a slit lamp, or with the collateral presence of other signs, which is the saying what? Blue hue of that will be coming from where? Why this blue coloration?
From deep.
Where?
From
Yeah.
deep.
Yeah. So there is a sort of and they're thinning, and you are seeing that things.
Yeah.
Okay. طيب. Plus.
Also, the characteristics of the blood vessels can give you a hint. If it's radial, the one is dilated, or injected is radial or not radial. This will give you the more hint about the level of the injection.
Okay.
Mobile or not mobile.
Okay.
Also give you a hint.
طيب. That's good. So now you are characterizing the redness and where is it located. What else? Okay, excellent. So you have there is a tenderness or no? You touch the eye. دائما we have, by the way, sometimes you are opening the lids with your hands or with the Q-tip. Which is better بالمناسبة? Huh? Which is better, to open the lid or you don't touch? I'm sad discussion. هذه على side discussion. Question. Ahmed, what do you think? Ahmed Al-Athman, we just examined you last week. Huh?
I would go with the you will be more just you know what you are touching exactly.
Yeah.
More than
طيب.
you can just
Okay, excellent. طبعا أنا there is no clear answer for this. There is some justifications. And I usually open it with my hand. But if you want to do that, you need to wash hands in between. طيب, this is important.
Yes.
Or you wear gloves in between. This is important. If you're going with the Q-tips, which is some people that are doing it, you need to be gentle, خاصة post surgical. لكن nevertheless you need to elevate the lid. Don't examine the patient without دائما quite a good part of the eye is covered with the lids, so you need to open them. Tumors can be hidden there. Melting can be hidden there. طيب, مهم جدا. Okay. كمل يا دكتور.
Yes. Plus, I have to assess the cornea. If there is any corneal involvement.
There is no corneal involvement. There is no corneal involvement.
AC to look for
nothing. The exam, other than the exam, it is nothing.
And the fundus, definitely to see if
Fundus
it's
is normal.
extended
That's
posterior or
good.
not.
Fundus is normal. Other than these localized redness, nothing is there. The other eye is normal.
Yeah, so
And there is no tenderness.
no tenderness.
Yes. Anything you want to do more?
I can apply phenylephrine.
طيب, هذا point of دائما debate. كثير من الأوفثالمولوجي discussion is something مكتوب في الكتب وموجود. بس لما you go dig deep, what is the rationale behind it? It's not so clear. We bring it in exams, bring it in MCQs, and يسألونك عنها. But you need to know it's for clinical examination. Phenylephrine that we are using, طبعا let's get some information about this. 2.5 that we are using, which is mostly in the clinic, is not the one meant by the early description of this test. Early description is 10%.
10%.
فنستخدم 2.5. In my opinion, 2.5 is not enough to differentiate between episcleritis and scleritis. It is good to differentiate between conjunctivitis and episcleritis and scleritis, and تفرق بين superficial والdeep. فلذلك يعني if you have it will be good to do it, لكن ما هو بهذاك التست اللي أنا have to do it، ولا هو التست اللي دائما كل ما نجيب السلايد وفي episcleritis people jump على طول it is linked to phenylephrine دائما يعني which is okay، لكن ما هو بعد ذات يعني importance بالطريقة اللي احنا نتصورها. طيب after that
not to forget to examine the other eye and check the IOP.
قلنا normal. after that, so what is your impression now?
Most likely episcleritis.
Mostly episcleritis. طيب هل فيه percent انها تصير scleritis؟ كم البرسنت انها episcleritis in this؟ يعني عطني اي رقم ترى ما احنا يعني.
I would say more than 70%.
طيب انا would go with 80% انها episcleritis. يبقى عندنا 20%. So how would you deal with this 20%؟ ها؟ Yeah. طيب هذا this will be the thing that we are. And now we want to do some classification. I mean some test or something to add to these 17 نخليها we push it more. Which will be the test. لأنه if you are dealing with episcleritis or scleritis, different management will be there. If you are dealing with episcleritis, in general, not this case. If you are dealing with episcleritis, usually it is self-limiting disease. It doesn't need that much of workup. It doesn't mean خاصة لما يكون في link to it. خاصة presence of skin disease, يعني saying episcleritis. So you give them just a topical maybe treatment and you will see. But in that case, when you see some possibility of this is not the right diagnosis, you give them follow-up. Okay? But mostly this is an episcleritis and then you will follow up the patient. طيب جاك البيشنت after follow-up in 1 week and didn't improve with the topical and is having more pain, and when you touch the eye there is tenderness.
You give him topical.
You give him topical. طبعا topical يعني it is reassurance rather. It is sort of placebo in episcleritis. Do I give it? I give it. I usually give FML. Yeah. بس أنا يعني the remote possibility of improvement is there. يعني دائما نتكلم إنه what is practical and what is written in the books. أحيانا نعطيهم non-steroidals. If that is recurrent, you can give them non-steroidals. If it is episcleritis, like let's say that is like this, and you diagnose the patient episcleritis, he'll come to you in 2 weeks time. طبعا we didn't do investigation لأنك you are saying this is episcleritis. Okay. It came after 1 week with improvement, and this one disappear. That's it. You say to the patient, you are fine. It was an episcleritis episode. You may have it in the future. Yeah. Goodbye. If the patient has still the pain is increasing and is having some changes, you may go to direction of scleritis.
Yeah, you have
and
to
then
investigate.
You need to do investigation for that case. طيب. Okay. Any question about this case? طيب, this is an episcleritis case. One thing that to mention about episcleritis, episcleritis is self-limiting. This is it is associated with immune or connective tissue diseases. بس في شيء disease that sometimes if you have a male patient middle age, you need to do it.
Gout?
Yeah, uric acid level. The uric acid level is sometimes, خاصة لما يجيك المريض يقول I don't have any disease. This patient has some skin changes, tend to be psoriasis. This patient. مع ان psoriasis more with the scleritis, لكن this patient tend to be scleritis. لكن احنا نتكلم انه the patient sometimes has no other diseases, and if he said repeated attack of this episcleritis, or you need to do uric acid, simple uric acid, you may see his gout disease. طيب. Okay. Let's see. Okay. This is a picture. You don't have any questions so far. طيب. This is a picture أرسلها لي اليوم نايف. وين نايف موجود؟ نايف. شكرا نايف. Thank you for sending this. It was just at 12 afternoon. الدكتور اللي وراك عبد الرحمن في الصف على اليمين. ايوه انت. ايوه كان فيك النوم شوي فنبغى نصحصك شوي.
So this is a 67-year-old, 2 weeks post-surgical intervention.
اي
This is a photo of the eye, of the right eye, showing conjunctival injection. Look, it looks like diffuse injection. I cannot comment on the cornea.
Okay.
There is like
the cornea mostly normal. يعني the disease is not in the cornea.
Yeah.
يعني or partially is not there.
There
What
is-
you are seeing?
there is like exposure of the sclera
Okay.
with some thinning with exposure of the subscleral uveal tissue.
Okay. This one, huh?
Yes.
Okay. And these are suture. ايش السوتشر هذه؟ Vicryl mostly. Vicryl sutures. بعد the people انت دكتور which level?
R2.
R2 طيب that's good. And you must be exposed to these sutures before. لكن maybe الزملاء اللي في الR1 know why. How do you know it? With the colors. We don't have a lot of sutures, colors in the eye. نعرفها. هذا واحد من الأشياء اللي famous. Vicryl suture. طيب. Okay, so there is هنا يعني necrosis and uveal tissue show. Do you which surgery do you think the patient had? دكتور. وش تتوقع؟ Forget about what they are saying to you. Think أنت وش تتوقع إنه في هنا surgery can be done in a nasal part of an eye with these findings.
Pterygium is one of the
Okay,
things.
excellent. So pterygium is one. What other?
Maybe strabismus. surgery.
Excellent. Strabismus. Third thing. ما في أحد من الشباب اليوم ما في أحد من الريتنا. So maybe it is a retina. عادة يعني البورت طبعا مختلف ما تصير هنا بس إنه I can show you one another one. But so these are the things that may happen at this area. أو إنها تصير يعني tumor that the patient had squamous cell carcinoma and removed, but it is in the context of pterygium. But most likely this patient had pterygium excision. طيب why the patient had this melting? طبعا this is the presentation. Which one is the presentation? Which one is the after treatment? توقع.
I'm gonna assume the left is the post. This one.
يعني at presentation طبعا هو he had 2 weeks surgery with these 2 pictures taken different time. واحدة منهم at presentation لما جانا بعد أسبوعين وواحدة أخذت في يوم آخر بعدها بيومين.
Okay, so I'll go with the one with the thinning is the later, and the one without exposure of the uvea. I would say this is post-surgical.
How many are saying this? Pre-treatment. He's saying like this. هو يقول هذه at presentation ER وهذه الكلينيك أو في inpatient. This is true. هتوقعون هذا؟ Majority. It's common sense. صح. You are right. But we just want to say it is not true. Your common sense is true, but this is not true in the answer. هنا في date هنا 17/12 يعني هذا الشهر ترى ما في شهر 17 في 12/17 يعني وهذا 15. This is the patient when he presented and this is 2 days after treatment. What you are saying is true ترى يا دكتور. أنا if you are presenting this to me لو جابها لي الشباب I will say like you. This is not usual to have the opposite in that fast. The patient was presented like this and that 30 لكن this is not the point of discussion. We can say why. لكن this is a case of what?
Could be secondary to surgery.
Yes. Okay. So surgical induced scleritis. The surgery was pterygium with mitomycin, and the patient also put in his eye non-steroidals, anti-inflammatory. طيب فهذا يقودنا entity that we are dealing with is a post-surgical scleritis, which is common that you may face it, all of you. طبعا إذا نتكلم عن diffuse nodular scleritis as rare, لكن this one is common. It's quite common, especially in ER. طيب, especially with the use of the mitomycin. But this is surgically induced. What is the problem with the surgically induced scleritis, Doctor? Infectious, excellent. So what do you want to do at this stage? Oh, yeah. So you take a tissue, or you take for culture and staining. Okay. So you need to know what is the organism. But in our case, we didn't do that, and it doesn't look like an active infected area. But this is what you need to do to rule out what is the commonest cause of bacteria. It's mostly bacterial, post-surgically. Pseudomonas. This is another information that is in the classic slides. So Pseudomonas is the most common organism post-surgical induced or scleritis. Treatment. In this case, you need to stop the offending cause, which is non-steroidal. So Voltaren was one of the causes. Mitomycin, I personally don't use it in post-regium cases because of such scenarios. And the patient had autograft, which is good, and there was suturing here, but the patient, he lost follow-up, so these regressed from the way of the thinning, and this one melted and caused some show here. And then after lubrication, withholding the non-steroidals, good lubrication with antibiotics only, يعني حتى reduce the blood force, patient healed in 2 days. In 2 days, that disappears. So you are treating the right. طبعا we were lucky. It's not the usual. Usually, if you treat them well and you know the pathophysiology of the disease, زي ما تكلمنا قبل شوي, mostly it was because it was an asterile or sterile necrosis. Because if you are giving mitomycin, you are reducing the normal healing, plus you are giving non-steroidals that is causing more melting. فأنت you have 2 factors that you need to deal with. Plus the dryness. أحيانا يكون في زي الدلن effect. The area will be dry, so the patient will have worse scenarios. This is the patient before the surgery, has bad pterygium. So the indication and the treatment was correct. لكن إذا طبعا يقول كلام في الساعة زين. أنا الحين أقول لو ما استخدموا مايتومايسين is better. بس this is the only thing. دكتور. Yes. Yeah. We'll give fortified and also oral. And this is good question. Sometimes we give subconjunctival as well. لأنه penetration with our medication in the cornea is much better than the sclera, خاصة when it is covered with the conjunctiva. Usually you give intensive treatment and in the coverage of Pseudomonas as well. Ceftazidime topically with vancomycin topically. Subconjunctival you can give as well. And oral, ciprofloxacin I usually give. Ciprofloxacin, oral. Now with the new literature that is saying moxifloxacin is good medication for penetration in the eye in general. But I usually go with the ciprofloxacin. طيب. Any questions? Let's go back to more common cases. This one. الدكتوراه. دكتورة أنت اللي في ما أعرف اسمعكم. Yes, go ahead please. هي أنت دكتورة النظارة. بعطيها الميكروفون ما نسمع. Any question about the previous case قبل ما تبدأ الدكتورة؟ ما في؟ بس. Yes.
Is it common for infectious scleritis to present without corneal involvement? Because most cases mentioned in the literature of infectious scleritis is an extension from corneal.
Yeah, no, I would disagree with that. And if you are talking about infectious scleritis, especially surgically induced, infectious, and تتكلم عن surgically induced ولا in general? In general. Yeah, surgically induced usually has nothing to do with the cornea. Infectious scleritis alone, without corneal involvement, without surgery, mostly common in 2 entities, at least in my experience. Herpetic, which is viral, can present only with infectious scleritis and TB, tuberculosis. There are certain series and report showing these two organisms are causative. If you have scleritis that is indolent, it's not responding to, and usually this is the triggering. Now you give them the treatment, immunosuppression, and in fact they don't improve. They get worsen or they're stationary. You need to go and take specimen and you send it. And we did this in 2 cases. One of them tend to be TB. It's a granuloma of TB, and you give them a treatment. The other one, we couldn't find the reason. Both can. Herpes in report is saying both. Mostly common with herpes simplex even. الدكتورة. قولي لي بس which level عشان بس نعطيك الأسئلة الصعبة ولا سهلة.
ريم الأحمدي 4th year resident.
4th, okay. Then we are a consultant now. Go ahead.
Barely. 36-year-old female patient with unilateral ocular pain headache for 1 month, treated with topical medications and no improvement. On photos, I can see multiple slit lamp photos of whichever eye, showing a sectoral...
Left eye.
Left eye. Okay, sectoral, what seems to be scleritis at the superior temporal side.
There is localized or sectoral redness
yes,
and
redness.
injection. Let's take it like this. And description-wise, we will not over. No, sometimes you expect me to bring you, مثلا في الexam, you expect me and I give you scleritis, I give you a question of scleritis. Maybe I bring you something else. Don't put this in mind, so in lecture or exams.
Okay.
Yeah, do systematic طبعا في الclinical and for the answering. Go systematic. By this you will not forget. Okay. And you will not miss anything. Yeah. Again, another information, the ones who are going to FRCS. FRCS exams, one trick that they are usually doing, he give you a case with 2 problems. مثلا, patient with pterygium, and there is an ICL inside. So you are attracted with the pterygium, and you explain for autograft and treatment and what else, and you go and you are failed from that station. Don't know why. There was an ICL inside the eye. فلذلك be systematic in description and in exam, so you'll not miss anything. Go ahead, please.
So in terms of history, I need to ask the patient whether she had this redness before, whether it's unilateral or bilateral, whether the patient she's 36.
Again, Doctor, so you need to be, this is a female, but you don't need to repeat things that was written. أنا قلت لك you are 4th year, so بشد عليك شوي ها. ما في مشكلة. This is a unilateral, it is written here. You don't need to ask about the other eye. Ocular pain and headache for 1 month. So apparently there is nothing before. Unless there is a repeated, if you want to ask about that, treated with topical medication and no improvement.
Yes.
Yeah.
I need to ask whether she has systemic illnesses. She's 36, she's young.
Okay.
She might have systemic lupus erythematosus, or she might have, it could be infectious. I need to ask whether she had prior infections.
Okay.
The cornea does not seem involved.
The cornea is normal.
Yeah.
But this is mostly a localized redness. You don't see here any redness. It's mostly localized. Yes. What else other than the localization of redness and vascularity? You see anything?
There's a violaceous hue at the
this
area.
Okay, good. And it's a bit elevated. Huh?
Yeah.
It's elevated. This maybe can show, but it's unfair. For example, I'll not put marks on saying elevation or no, but mostly it makes, and it is elevated and there is blue hue here. Okay. So anything, these are the exam. Other exam is normal. We are dealing with a sectoral redness with elevation and everything. So most likely, is this episcleritis or scleritis or conjunctivitis?
This looks like scleritis.
Scleritis,
yes,
okay.
Because of the
when things are clear, just mention it. You don't need to be safe. It is clear that it is scleritis. You don't need to mention it is episcleritis. It's mostly a nodular scleritis. Okay, nodular scleritis. In this age, in that presentation, you need to ask specific questions about the systemic association. Okay. What other? You said systemic lupus. What else?
Rheumatoid.
Rheumatoid arthritis.
She could have. Wegener granulomatosis.
Okay, Wegener. Okay. Why you specify Wegener granulomatosis?
It's most commonly associated with scleritis.
Is it most commonly?
Uh,
Most commonly, you saw a patient.
It's rheumatoid arthritis is the most common in elderly patients.
Excellent. So
This is
these
a
are
young
the other
patient.
information that we need to tell you that mostly are associated with rheumatoid arthritis in 30 to 50%. Wegener granulomatosis is rare, and yet we are putting it in differential diagnosis and we are investigating for it.
Because
Why?
it's life-threatening.
Life-threatening. And if you miss a patient with Wegener granulomatosis, this is something major. Okay, the patient it's not losing the eye, may die. Okay, if it is important to do the investigation. أحياناً, when we do the test or the yield of the test, there is something we call the yield of the test. The yield of the test either because of it is common or it is most likely diagnosis, or you want to rule it out because of the life-threatening or vision-threatening, or you want to start medication that you need to avoid the complication of your medication based on that. يعني, you need to rule out tuberculosis if you are giving a patient immunosuppression or steroid.
Yes.
In our area, in the state or North America, they don't need to do that. These are things that you need to practice it. طيب. So this is a patient, we ask about questions, things, tend to be she's having rheumatoid arthritis and treated with hydroxychloroquine alone. So in this case, what will be your treatment?
I could give her a trial of non-steroidal anti-inflammatory.
Okay, you did, and after 1 week, patient came back with severe pain, no
Then
improvement.
I will start with oral steroid.
You want to do another trial?
Yes.
Okay, this is written in the books, and this is the classic answer. But for me, I usually don't do that, and the chance of having improvement in the other one, إلا لما نتكلم إنه non-specific and you are shifting to a specific one. Okay, mostly it is not that much, but yeah, this is need to be mentioned that you need to try another family of non-steroidals. In this case, before that, before you go to the treatment of the steroid, anything you want to do?
Yeah, I need to refer her to the rheumatologist that she's following.
Okay, this is another take-home messages of the point that we are discussing. Mostly, episcleritis and scleritis and uveitis أحيانا نتكلم عنها is need to have with you an internist on board, either a consult or co-management. Okay, and the good part of they will help you in terms of reaching the diagnosis and in terms of controlling the disease. For these patients, you need to deal with them in that level. But in this case, she volunteered to you the diagnosis. She is a rheumatoid arthritis, and with this presentation, you would expect she's controlled or poorly controlled.
Poorly controlled.
Poorly controlled, because the presence of the eye finding in these cases indicating in a poorly controlled. And if you dig in the history, your patient will tell you, I have joint pain, I still have problems with. This is the common scenario. Okay. What you will do after that, if she is telling you this, you are practicing here at KKESH. What you will do?
So if we give another trial for non-steroidal anti-inflammatory.
لا شو ما بخلص شو. Now you are saying there is a poorly controlled patient in front of you في الإيار.
I need to refer her to the rheumatologist and decide.
Tell me what you will do now في الإيار. You will call the medical doctor here.
No, they rarely help.
They were.
She already. That's what I was going to ask.
I'm saying to you, this is what I want to. We want it to be practical, and we don't want to say something that is not really present. That is not something that you are not applying it in your practice.
Yeah.
If you have patient with these cases, you have two options. Either she or her treating physician. زين, and you write a report, detailed report, to him or to her. This is what you're suggesting from the point of view that the patient need to do so and so. If you know him, like in the state which is better, and we don't reach to this, if you are practicing in King Abdulaziz, مثلا, we know the rheumatologist اللي treating this patient. أرفع السماعة على دكتور محمد أمير, دكتور بديو, any one of them. I have this patient of yours. She is not controlled well. You need to. He said, I will see her next week, madam. But for you, if you are seeing either in private or in another hospital, and that you cannot reach directly to the consultant or the one treating, you write a full medical report and give it to the patient. And then you can treat with non-steroidals if you want, meanwhile, to give the treatment. But that is the ultimate treatment.
Yeah.
Okay. This is important. In this case, you give, if you control the rheumatoid arthritis, they will improve. They will improve without giving them steroid. Okay. أحيانا, if it is severe and necrotizing, you need to give steroid, oral steroid and tapering, and you need to follow them with you and your medical. So in teamwork, it's not reaching the diagnosis only, the end result in these cases. Reaching the diagnosis and formulating the proper management plan. You don't say, oh, I'm ophthalmologist, she's rheumatoid arthritis, okay, forget about this. It's not. You need to reach to the proper treatment and explain for the patient. Okay.
So I have a question.
Yes.
So she said that she has rheumatoid arthritis. Do I
Yes.
need to reinvestigate, or so
You
should I
don't-
believe her?
You don't need to.
Even if I don't know the
Yes,
consultant?
unless, this is a good question. Unless you want to give steroid and you do it yourself, you need to do the investigations from multiple reasons. You need to know what is her status, blood, kidney, liver, all this, and you need to rule out infectious etiologies that may be activated with immunosuppression. She's in hydroxychloroquine, which is weak. It's not immunosuppressive. Okay. If you are giving the immunosuppression, you need to give steroid. If you need to do investigations. طيب.
Okay.
Okay. Questions? Huh. We usually go, if it is severe, usually go with 1 milligram per kg. In these cases, it is less than the uveitis. Mostly, I go with 0.5. Yani if the patient is 60 kg, I go with 40 or 45, and I taper it quickly than this. And this is not dependent, usually treatment that we are depending on. And this will take me to the slide that we skip. And this is a good slide. And we don't need to skip it. Yes. This is, by the way, these are, okay. This is a summary of a series of studies. اللي هي site studies, systemic immunosuppression control study or trials. They take all the immunosuppressive with the different immune-related diseases. If you to go with the arrow, you can see scleritis. The treatment here, cyclosporin, azathioprine, methotrexate, Celcept, cyclophosphamide. These are, at that time mostly, or even now, these are the usually weapons that we have. This is the strongest one and the most destructive. We don't use it much, cyclophosphamide. We are in between, في scleritis, between methotrexate and Celcept. You can see the result in 1 year is comparable. Methotrexate is better in terms of in a long record. It is maybe the highest. The other second one is maybe the Celcept now. Cyclosporin is having more complications, but usually we are between these two medication as steroid-sparing treatment. But let's say, Dr. Anwar, the internist call you back, or you call him, and said to you, okay, what do you suggest? Which treatment? In this case, I would suggest to add methotrexate to her hydroxychloroquine. Okay, any questions so far?
Doctor, I actually have a question. Can episcleritis be induced surgically or not?
Unlikely. If you think episcleritis secondary to, think about biogenic granuloma or inclusion cyst or something else.
Okay.
Okay. This is another case. نشوف شو الكيسز هنا. Okay. Anyone of you guys, one male, one female. Let's go now with the male back. ها؟ ما في أحد منكم. دكتور أنت اللي وراه عبد الله. أنت عبد الله وراك واحد. أيوة. أنت أيوة. لا أوكي. That's good. That's good position. Okay, go ahead. يكمل دكتور. 62 female with unilateral severe pain and redness of vision. 6 weeks back she underwent retina surgery. Here is the retina surgery, doctor. I see the area. What do you see? So you are dealing with an area of melting and necrosis of the sclera. For mostly, what is it? Is it diffuse? Okay, so you need to tell this is a mostly necrotizing scleritis with ischemia and thinning and melting here. So in this case, what do you want to do as investigation-wise? Let's skip the diagnosis, skip the clinical exam and the history for sake of time. Okay, so we'll take it for culture. Excellent. So, okay, this patient tend to be Pseudomonas. Pseudomonas. Infection. The lab gave you that is Pseudomonas. How would you treat this patient? With topical 45, mostly ceftazidime, and in this case also we give an injection of ceftazidime subconjunctivally. And the patient, luckily enough, she didn't have the follow-up, but let's, we're talking about injection. Will you inject steroid in cases of scleritis? Let's go back to the question حقت الدكتورة ريم. Will you inject steroid here? Okay. Okay. So if you are, what are the prerequisites to start subconjunctival? By the way, in 2000 تقريبا, when we were a resident that time, if you say subconjunctival steroid in scleritis, you will fail. ذلك ريد فلاج ويكلمون لك اللجنة الثانية and they will fail you, يعني موضوعك منتهي. لكن now this يعني give you and give us as a teacher, and there is no thing, black and white in medicine. You still have, if you have justifications, you can defend yourself. In these cases, we usually don't give before, like now we have limited and series of cases, and now it is a practice to give some cases subconjunctival steroid. What are the prerequisites? يا دكتور قال لي بس اسمك تكفى والليفل.
محمد بن منيع R4.
Okay.
Prerequisites for subconjunctival or subtenon triamcinolone injection in scleritis patient is non-controlled patient of anterior non-necrotizing scleritis. It has to be non-necrotizing,
Okay.
which failed and oral steroids and possibly immune modulatory medications,
Okay.
and without posterior involvement. If you have a necrotizing, it's absolutely contraindicated.
طيب لا تصير تدمج الاشياء وبعدين you skip things. We need to know. No. First you say there is no necrotizing. I'll
Yes.
take it.
Yes.
Posterior scleritis, yes
give.
and no. You can give. If it is unilateral and there is no systemic link, you can give. طيب what else? One important thing you need to rule it out. Infection. In that case, this is why I remember, in that case, when you are suspecting infection or there is possibility of infection, سواء herpetic or fungal or TB or something, you don't give. And these are the cases, when you go, if you discuss this in international meeting, Dr. Jab is well-known figure in treating scleritis. Immediately you discuss this, he will show you a picture of his cases. I think he's keeping it in his pocket. He will show you a picture of a melting and lost eye because of subconjunctival steroid. And the argument of that, this is not the end of discussion if you are discussing this. That must be a necrotizing to start with or an infectious. And we are having a lot of cases. We can show a lot of pictures. By the way, this patient, we gave her subconjunctival. Why? And the control of rheumatoid arthritis was full with immunosuppression. It was in metabolic state, didn't improve much. So we gave, because it is unilateral, again, these are in favor of giving. If you have bilateral scleritis, it doesn't make sense to give injections. Orally will be enough, and you are dealing with a systemic disease, mostly. Like if you have unilateral, non-necrotizing, non-infectious, the possibility and of giving subconjunctival steroid is there. You can give triamcinolone. Yes.
Doctor, there was a multi-center study done by Sohan, I believe, in 2011 about
Yes.
subtenon injection of steroids in non-necrotizing anterior scleritis.
Yes.
About 68 eyes were included, and none of them had melting.
Yeah.
And the success rate was very high, almost reaching 96%.
صحيح.
But complications like high IOP, cataracts were observed.
Yes. Well, again, the argument with these is, these are even the disease itself. It can give. You're giving the oral steroid, they will have. If you give the oral steroid, they will have glaucoma and they will have cataract as well. But it is something that when you say the list of the medication, that it is something in your table that you can use and targeted patient where you will use in base of real justification. Yes. If you have unilateral, even if you don't have systemic association with unilateral, this will be the best cases to inject them. And in this case, maybe you remember the Muhsin. This case you gave her and she was fine. She's free of any relapse for يمكن now 1.5 years or so, without going to the hassle of giving steroid or giving another medication if she is in methotrexate already and controlling rheumatoid arthritis. The first step in this case, we ask the medical or rheumatologist to control her disease. They said this is the maximum, and she came back with joint-free disease. She is mobilizing, she is working, has nothing problem, but with this indolent redness and pain in that time. So we left with subconjunctival injection of steroid, and she improved after that without recurrence. Yes. Go ahead.
Sorry, too many questions here, but last question.
This is the time for questions.
In recent literature about the paradigm of management of scleritis, we have other treatment rather than the methotrexate and the cyclosporine. We have the infliximab, the rituximabs. Would you rather reach those kind of treatments of immunomodulatory or the subtenon injection?
For idiopathic without systemic association, usually we don't go with this. Unlikely that I will treat a patient with solely scleritis without systemic association with immunomodulatory biologics. Let's say it like this. Mostly I will go with local treatment or subconjunctival treatment, or the long record that we are having اللي هو methotrexate. Like if you have certain disease, yeah, you can. And this is now you come with the help with the rheumatologist. You need to do some workup, detailed workup. Likely, the most of the patient they will have disease, hidden disease there. Okay. Last, question. Yes. أسمعك. There is a question. اسمع. أيوة. تفضل. Posterior, yes, you can give it back subtenon. Yeah. And by the way, for posterior scleritis, it is associated with, what are the findings of posterior scleritis? Good to mention it, قبل ما ننسى. You can have macular fold, okay. T sign. In the series that we published في International Journal of Ophthalmology مع الدكتور بارقي الله يذكره بالخير محمد. I don't know where is he now. والدكتور أشلي when he was a medical director here. 9 out of the 12 cases of posterior scleritis, they were having T sign. Okay. Do you know what is T sign in posterior scleritis? Why? From where it's coming? What is in the optic nerve? Yes. Yes. There is collection of fluid around it. Huh? So these are the fluid collectors that give you like a T shape. طيب. These are pictures. Okay. كان في سؤال؟ لا لحظة ترى كنتم أنا دكتوري. Yes.
Why not to start with fluoroquinolones, for example, since they have better activity against
Excellent. Which generation of fluoroquinolones will be more effective against Pseudomonas? Huh? Is that true? Yeah, that's good to raise this point. Now we'll go back to selecting which antibiotics. In ophthalmology practice, usually in our hand, take it as a general rule. Ceftazidime fortified is the best for Pseudomonas. لما تتكلم عن all side effect and preparation and ready available with Pseudomonas. Fluoroquinolones عكس الكيفالوسبورين. When you raise in the number and first generation, second generation, third generation, fourth generation, يزيد الكفرج of gram positive و atypical mycobacteria. فذلك نعطيها كثير post LASIK to avoid mycobacteria. بينما ciprofloxacin, which is the first or يعني نتكلم عنه mostly second generation fluoroquinone, is the good treatment of Pseudomonas. فكل ما العكس، فانت لما تروح فوق تقل. فلذلك if you want to give, you give oral ciprofloxacin, and we don't have it يعني readily available as a topical form. So you give oral and you give ceftazidime as the best combination. By the way, gentamicin is a good medication against اليماني glycoside, بس إن المشكلة toxicity. زين. فلذلك these are the two treatments usually we are giving. Question. By the way, this is the paper that I mentioned to you. You can see. By the way, our finding in scleritis in our يعني area is almost the same. Non-necrotizing enteroscleritis was the most common, luckily enough, and usually it is associated with good visual recovery. They don't have and good response to treatment. كان في أحد رافع يده هنا؟ Yes, Doctor.
In case of rheumatoid arthritis, was it risky to give subconjunctival in presence of sort of scleral thinning?
Which one?
Previous case.
It is risky. طبعا هنا احنا نتكلم عن انه thinning, is it associated with active necrosis ولا لا? And this is why I سألت الدكتور قبل شوي محمد انه what are the prerequisites? If you have active melting, necrosis, it's not only thinning. If you have active melting and necrosis, you don't give. Like if you have mostly the nodular and the inflammation will be intense, causing like subescleral edema, collection of fluid. This is what he give you, the raised and hue-like. So it is fine. طبعا you will not go directly to the area of thinning. You will inject surrounding it, and the patient improved. فهو الفيصل, it is not the thinning, it is the active necrosis هو اللي contraindication. Other question? طيب, we have grand round, do we? Case presentation. And I just want to announce to be with the grand round I think is cancelled. فذلك بيكون عندنا يعني ساعة من الوقت على الأقل 5 minutes more. Okay. So this will be the last case that we discuss. اللي هي when you have a patient with inactive scleritis or controlled scleritis. And no active thing, and patient is controlled with methotrexate, she is doing fine. You have the complication that the patient had, which is mostly cataract or glaucoma, and you want to operate the patient. This is an example of a patient with Wegener granulomatosis, treated with rituximab. He's doing fine, controlled, but he's having poor vision because of these findings. Knife, what do you see here? Tell me quickly كده بس عشان نخلص. That's good. This is one important thing to know.
There is a temporal blackish hue. It seems like a previous attack of scleritis.
Yes.
And
there is thinning. Sometimes you will have this as scleromalacia perforans, which is another terminology that you need to read about it. When you have thinning and there is no active melting, and mostly associated with rheumatoid arthritis. Yes. But this one is an old sequelae of scleritis, this thinning that we have. And this is what we want to avoid. لما تشوف المريض إنه أحيانا why we give them steroid, why you give them immunosuppression, we don't want to reach to this thinning. يعني I have patient, يمكن الزملاء اللي يتابعون معي في ال KKESH clinic, a lady with rheumatoid arthritis, and she is okay now from eye point of view, she's seeing 20/20. Now the problem with her, the cosmesis. The whitening of her eyes is usually blackish because of the previous thinning. She was not treated well in the rheumatology side, that we cannot fix it after. طيب. ففي thinning هنا. Okay,
yes.
What else?
And there is what looks like cataractus changes in the lens.
Okay, and there is posterior synechia.
Yes.
So in this case, you are right saying that you need to have quiet. You need to rule out any posterior pathology, sure. Because these cases, they may have damaged optic nerve, or they may have, and this case has macular problem. We did the surgery after. We consented him well, but didn't improve in one eye because if retinal membrane, because of the repeated attack of inflammation, didn't go to good vision. So this is important to rule out. Most of these cases will come to you late. So you need to know the status of the posterior pole. Even if you do get excellent surgery and the patient didn't, he may be not happy with you. So you need to consent him or her well and to know what you may find. This synechiae secondary to inflammation inside the scleritis alone most likely will not cause synechiae. Like mostly it is associated with sclerouveitis, and this is repeated inflammation inside the eye, so they have synechiae. So you need to have them treated, controlled before the disease, the surgery, and you need to give them steroid as well. That's what we are dealing with the patient with uveitis. You need to have them controlled and with systemic steroid. In the surgery, what are the things that you want to avoid in surgery? حمود شو رايك؟ حمود شو رايك؟ What are the things that you want يعني operating in scleritis patient, which الاشياء اللي يعني الاشياء اللي تحطها في بالك؟ Yeah, we mentioned this لأن technically inside the surgery. طيب block بداية. You will give local, topical, systemic. Huh? طيب, what are the risks in this case? Sometimes you have staphylomas in these cases. Hidden staphylomas, anterior staphylomas, posterior staphylomas. You need to, there is a risk of perforation. You need to be cautious in that. Anesthesia is important to be taken in consideration. Then you need to be ready with hooks inside the surgery. A possibility of 3 pieces IOL need to be there. Okay, what else now in surgery? What you will do? You will do ECC ولا فيكو؟ ليش؟ Yeah. And okay, so mostly you will target the cornea. They're not to blame. Sclera usually go to here, so you will induce some inflammation. So phaco, clear corneal incision phaco is needed. It's to avoid manipulation of the sclera. Then you will release these synechias and do the surgery. And after that, you need to control them with the anti-inflammatory treatment. You taper the steroid and maintain what they are having. Okay, question, Naif?
Yes, Doctor, regarding patients with anterior staphyloma, what's the rate of spontaneous rupture?
Very rare. Very rare. Unless they have tumor, trauma, or you go with injections sometimes. بالمناسبة if you have anterior staphyloma, you go with a Honen balloon and you press too much. فذلك دائما when you are doing something, keep in mind the other status of the patient. It will be annoying to me if I'm doing a surgery, one of you are giving the local anesthesia, and the patient is having 0.9 cupping glaucoma, and you are putting pre-bulbar and putting Honen balloon for 5 minutes. Again, a patient who is recently operated, using all of these measurements, pre or post, you need to take the patient whole in consideration. Okay, so in conclusion, you don't want to exceed the time. Scleritis is a challenging disease to diagnose and to treat. When facing patient with scleritis, one should have detailed medical and surgical history. Investigations, when needed, should be tailored according to the case. Treatment should be specific and safe, yet sufficient in controlling the disease and to prevent recurrence. Regular and close follow-up for those patients is crucial. It's not these cases that you will see the patient and discharge them. You need to have good control and follow-up. Okay, thank you. Can take 1 or 2 questions if you have. Doctora. 3 questions. طيب يلا. Yes. It's not common if you are going corneal. Like if you are going with ECCE, it is sometimes common to induce inactive scleritis. Okay. Some patient who is inactive, you have activation. من كان رافع ايه عبد الله. Again, what is the question? Posterior scleritis, okay. Posterior scleritis, BI, can you tell me why? But it doesn't make that common finding, and you will see an angle closure in glaucoma إلا لما يكون عندهم extensive exudative retinal detachment, maybe. But I don't think this is something, and you need to control them. That will be the easiest way rather than to do a prophylactic PI for them. If you leave the cataract and to get swollen. You may have rare cases you encounter them for that, like, and I don't think this is something we can generalize. ذلك واحدة من conclusions اللي قلنا قبل شيء, you need to tailor it according to the case. But in general, posterior scleritis shouldn't cause for you angle closure glaucoma. Question, Abdurrahman. Autograft conjunctival, yes, yes. With fibrin glue is good. لو شفت الحالة اللي قبل شوي, لو شفت الحالة يعني لو حط glue will be worse than suturing. يعني we put suture ولا سلمنا. Suture was there ولا سلمت. فهي القضية أن when we put the glue you need to make sure that the conjunctiva is approximated all. And you need to glue the autograft and the recessed conjunctiva. So if you have small one, you need to do. Like, and if the conjunctiva has the tendency to go out, you can put 1 or 2 sutures to hold it there. Like if it is localized only small pterygium, with just cutting small piece and you put the autograft, it's fine. القضية you need to approximate both ends. يعني لازم تكون approximated. Okay. طيب يعطيكم العافية. Who is giving the case presentations? Or who is supervising the case presentations? عادل موجود? We just want to announce when they will start على أساس إنه the people who is going to have break. ها؟ كم؟ 2. So now we can go take 5 minutes break.
دكتور عادل حيدان in the way بس قال إنه ابدوا. Assalamu alaikum everyone. My name is Rihab Rashidi. I'm going to present a case. We will start with the case presentation. This case came during my rotation in National Guard. This is a hint about the case. I have a 41 years old Indian male victim of blast injury after a large wheel exploded directly over his face while working. Came to ER and intubated immediately as his Glasgow coma scale was 8 and was agitated with a bloody face. Primary survey done by ER and secondary survey showed multiple facial laceration over the nasal and eyelid and chin with no active bleeding. Preorbital swelling and small fracture of the orbital wall, bilateral small orbital floors fracture and communicated fracture of the nasal bone. This is an illustration of how the trauma happened to him. So, seen by ophthalmology on call, examination showed in the right eye. Unfortunately, I don't have photos in first presentation. Right eye showed severe preorbital swelling, temporal chemosis, hazy cornea with grade 1 hyphema and irregular dilated pupil, and there was no view to the fundus. Left eye, the ruptured globe with prolapsed intraocular content with lower lid margin laceration. Impression was severe left eye injury and left ruptured globe unlikely to be salvaged or repaired. Plan was case discussed with the on-call consultant. Patient have very low Glasgow coma scale and globe unlikely to be salvaged and repaired. So they recommend to be seen by oculoplasty, inoculation versus evisceration left eye, and to inform his family or relative regarding the consent preparation. As you know, he's an Indian and there was language barrier, and to keep both eyes covered with gauze and eye shield. So, oculoplasty team saw the patient and their exam was preorbital swelling with right eye with temporal chemosis and hazy cornea with grade 1 hyphema with irregular dilated pupil and hazy view secondary to vitreous hemorrhage. And the left eye, ocular content are extruded with the exposed uvea and ruptured globe and lower lid laceration with first degree burn, no lid malposition. Their impression was left rupture globe, non-salvageable with complete intraocular content extrusion. Referred to CT was done. We will show the CT. And their plan was discussing with the family of the nature of the condition, rupture globe with the explosive and extrusion of the intraocular content. And the procedure was a left evisceration with possible implant with left lower lid lateral margin laceration repair. Outcome and benefit was explained to the relative. Also to show was discussing regarding preventing an infection focus. And we will maybe we'll need in the future eye prosthesis for cosmesis. This is the CT referring to. I will just read the parts of the globe. Show bilateral swelling with extensive subcutaneous air. The left globe is dense, likely representing rupture globe with vitreous hemorrhage. This is the left eye during surgery. This is the photo. As we can see, all the content of the At the day of the surgery, we found that the lateral part of sclera was lacerated 8 mm from limbus, and also we found that the lateral part of the conjunctiva was also lost. We elected to not put a sphere implant in order to prevent any fornices shortening or post-operative extrusion of the implant. So the procedure was left evisceration with no implant, with left lower lid lateral margin laceration repair, with central temporal tarsorrhaphy, and maxitrol applied after patch. This is first post-op visit. As we mentioned, eye patch removed, no bleeding, mild lid swelling, intact central tarsorrhaphy suture, conformer was in place, and there was no sign of infection. So post-op medication was started. This is the photo post-op. So during the follow-up, now we are following both right and the left eye. During follow-up with the right eye, there was mild preorbital swelling, clear cornea, resolved hyphema, irregular dilated pupil sphincter tears, and vitreous hemorrhage over the disc and macula, and preretinal hemorrhage inferiorly. There was query inferior retinal break, and left eye was mild lid swelling, intact central tarsarophy suture, and conformer was in place. Plan was bedside B scan for the right eye and continue same treatment for both eyes. This is the photos. Okay. During B scan done for the right eye, patient was very uncooperative, but the B scan for the right eye showed 36-degree shallow peripheral choroidal detachment, moderate diffuse vitreous hemorrhage noticed with some clot mainly posteriorly at the papillary area, with some area of edema with some fold detected, no RD or any image of intraocular foreign body, no other or more details. But their impression was due to hemorrhage and blood clot concentrated at the pre-papillary area around the disc. Serious investigation needed to exclude a great suspicions, which is optic nerve avulsion. So suggest to do CT or MRI exam in order to get more detail if possible. This is some photo of the B scan. Okay. Case discussed with the neuro-ophthalmology, and he advised to wait and see and follow up after 3 weeks for neuro-ophtha evaluation. And also the case was discussed with the medical retina for observation and continuous same treatment, and to proceed with MRI and CT to get more detail. Brain MRI and CT was done. Case discussed with the radiologist regarding any evidence of the right optic nerve insult, and image were reviewed and showed right optic nerve is free, no insult or compression. So during the follow-up of the right eye, resolving vitreous hemorrhage is still not clear over the macula, but preretinal hemorrhage inferiorly was observed, and optic nerve head visibly clear, no any anatomical insult. This is the photo. So here we end our case at this point. So just briefly talking about whether to do evaceration or inoculation, we elected to do evaceration in this case, as we can see the risk of sympathetic ophthalmia. The purpose of this review to find out the risk of sympathetic ophthalmia after evaceration and inoculation, particularly in cases of penetrated ocular, either surgical or non-surgical injury, and to know about the cosmetic outcome of evaceration and inoculation. Ophthalmologists around the world, whenever dealing with case of penetrating ocular injury, might thought to be help in deciding whether to keep the traumatized eye or remove it. And if they finally decide to remove it, they will be able to choose between evaceration and inoculation for the best cosmetic outcome, and to minimize the risk of sympathetic ophthalmia. The result of the review are the following. Inoculation is found to be a best protective measure against development of sympathetic ophthalmia, as it was thought to be, since there are reports of sympathetic ophthalmia occurring not just after evaceration, but also after inoculation. But the cosmetic outcome of evaceration, as opposite to inoculation, is found to be better. The incidence of sympathetic ophthalmia is approximately 2 to 5 in 1,000 for the open globe injury. Evaceration and inoculation are surgical options for severe traumatized eye to reduce the risk of sympathetic ophthalmia. Evaceration involve the removing of intraocular content of the eye, leaving the scleral shell, where inoculation involving removing the complete eye. It has been suggested that the chance of developing sympathetic ophthalmia are very low when the surgery performing within 10 days of the initial trauma. However, evaceration has not always been the favorable treatment option. In 1887, reports theory of patients who develop sympathetic ophthalmia following evaceration. Furthermore, reported 4 cases of sympathetic ophthalmia following evaceration, but did not document how many evaceration were performed. However, more recent large-scale retrospective analyses have reported no case of sympathetic ophthalmia following evaceration. So just to conclude, a patient presented with ocular trauma require careful consideration. The key issue to address are the visual potential of the patient and the risk of sympathetic ophthalmia and informed patient preference. And it's very important to accurately identify ocular trauma, particularly when present with patient with multiple injury. Thank you. Actually, I don't know. I wasn't in National Guard, so I don't have the last updated regarding the patient. Yeah, he has multiple follow-up, but because he's Indian, I don't know if he came to the clinic or not.
Doctor, if I may ask you, do you prefer evaceration over inoculation or? طيب السلام عليكم دكتور سارة العويضي fourth year resident. I'll be presenting a case that we've been struggling during follow-up for around 9 months until we knew what was the cause of this mystery. So did we miss it? This is a 34-year-old female, medically free, first presented to National Guard Hospital to the Family Medicine Department in 2018, complaining of sore throat, lower back pain, constipation for a long time. They did paranasal x-rays, all was normal. The patient was discharged from the clinic as case of simple sinusitis, on medications, diet advice, and reassurance. Then, 1 month after that, she presented to ophthalmology complaining of pain, redness of the left eye for 2 days. Vision in the right eye was 20/20, left eye 20/200. IOP was 18 in both eyes. Slit lamp examination, clear cornea, AC reaction of 2+, with
round regular reactive pupils and clear lens. There was a clear vitreous with normal fundus and no signs of inflammation in this presentation. The patient was labeled as anterior uveitis of the left eye and discharged from the clinic with medications and workup plus follow-up. Patient was seen the other day. She was still complaining of pain and more decrease of vision or worsening of vision. Vision is now counting finger with IOP of 47. I forgot to mention that we gave her topical steroids in the first presentation. On the examination, there is now corneal edema plus 2+, decreased corneal sensation, pupil, there is sphincter atrophy nasally with spiral constriction. Dilated fundus exam showed around 6 to 8 disc diameter of subhyaloid preretinal hemorrhage with a gravity level and intraretinal hemorrhages. As you can see here, this is the hemorrhage, the preretinal hemorrhage with the premacular hemorrhage as well, and Roth spots here and there. A slightly hyperemic disc as well. The impression was to rule out hyperviscosity syndromes, myeloproliferative disorders, steroid-induced glaucoma, and herpetic uveitis. We started the patient on Pred 40Q 1 hour, ocular as well, full topical anti-glaucoma drops, as well as systemic Diamox. Acyclovir also was started, oral and topical, and we followed the patient. The impression is a case of herpetic uveitis with secondary open-angle glaucoma, trabeculitis, plus minus query, all CRVO maybe, or atypical. Patient was discharged from the clinic with full medical treatment, and we were waiting for the results of investigations. Patient was seen, and she reports no improvement. IOP now is 20 on the full anti-glaucoma, clearer cornea with no edema. There is now mutton fat KPs with the still AC reaction of 2+. FFA showed delayed in the transient time. You can see here, this is the arterial phase. There is a delay in the filling with the 18 second. This is 20 second. We're just starting the transient phase. And then as well, you can see the delay. Here you can see slightly hyperemic or slightly hot disc. No periphlebitis. This is the expected defect from the blockage effect of the hemorrhage. So this is the hot disc. OCT also was done, right eye normal. The left eye showing hyper-reflective material, subfoveal, with inducing shadowing. This is corresponding to the clinical perimacular hemorrhage, and the shadowing here preventing us from assessing the photoreceptor or ellipsoid zone integrity. So this patient is HIV negative and positive quantiferon. CT chest was done and PPD, both were normal. So we're just dealing, the only positive finding of the investigation was positive quantiferon. CT chest normal, impression, finding suggestive of the same primary diagnosis, herpetic uveitis, secondary open-angle glaucoma with central vein occlusion and Roth spots. Better control of both IOP and the inflammation. We consulted ID regarding the positive quantiferon and also hematology for the Roth spots. Patient continued on her same medical treatment. Hematology reported that there is no clinical or lab evidence of lymphoproliferative disorder. ID recommended that we start full anti-TB medications and we start steroids, IV steroids, then oral, as long as the patient was not benefiting from only antiviral medication. So we continued the IV acyclovir. At this time, patient was admitted. And also the topical ocular drops. She was also started on Cellcept 500 milligram BID. During her stay, during the admission, there is some improvement. Patient is having occasional cells with early iris atrophy between 7 to 8, the same area of the nasal changes we saw in the first visits. Otherwise, same findings. Impression, left eye herpetic uveitis, definitive diagnosis with secondary open-angle glaucoma with venous stasis retinopathy, atypical CRVO. Her vision is still very poor, cannot rule out central retinal artery occlusion as combined mechanism, so ARG as well was requested. At that time, patient was on full anti-TB for around 2 months. We doubt the need of the full anti-TB, especially that our patient was, we were doubting as well her compliance. So we discussed again with the ID. They just recommended to continue at least the isoniazide. So we did that. We tapered the oral steroids. We tapered as well the acyclovir to 400 milligram. Ranitidine and vitamins were given. Silcept also was decreased to once daily and then for 2 weeks and then to stop it. Written opinion was as well taken. Hand motion vision cannot be explained by the retinal findings. There was a peripheral membrane and it was sparing the center of vision. No active lesions in the fundi. VEPs were done and it was normal bilaterally. So this is the picture after 3 months. You can see much improvement of the hemorrhage and almost no premacular hemorrhage. All the rough spots disappeared and no other new lesions. Though at this time, patient was reporting counting finger and hand motion vision every time, between hand motion and counting finger. This is the OCT of the left eye. You can see it is normal and we can make sure that all the layers are intact. So this doesn't explain her hand motion. 5 months later, HLA-B51 was positive, and the patient was reporting that oral aphthous ulcers are present, but fundus findings are really not suggestive of the Behçet. We repeated the FFA as well, no evidence of Behçet vasculitis. Same impression, we're still with the herpetic uveitis secondary to high IOP, though controlled now, and the patient is still complaining of hand motion vision. We didn't know what to do actually for this patient. We gave her report and we asked her to seek other advice, to take another opinion. The patient, just to make sure, we did everything. We did MRI, brain, orbit, all were normal, even sacroiliac, all were normal. So dealing with persistent hand motion vision on the left eye in a medically free patient, all investigations almost negative. At that time, we stopped all medications. The ocular exam was totally normal, but patient was with hand motion vision. What was suggested by Dr. Debasi is to do fogging. So we did the refraction. We didn't start fogging yet. Vision was 20/30. So this is a malingering patient. It was so disappointing, especially for Dr. Adel, that he suffered trying to know what was it. Did he miss a CRAO? Did he miss an etiology that he didn't really treat on time? So this was a malingering patient. She was seeing 20/30 even before starting the fogging. So yeah, it was a premacular hemorrhage that resolved, and that's it. With anterior uveitis that was treated with the topical steroids. So take-home message: keep in mind that patient might be malingering, but please don't put it as first. You should do all the investigations, utilize all the facilities you have. Never hesitate to ask for help and to ask for other opinion. Sometimes you're misled by the patient symptoms, or maybe sometimes you get involved into the patients and you feel guilty that you might did something wrong, but do all the investigation, give the proper management, and then take other advices and save the patients. Thank you. That's all. Any questions? So it was the premacular hemorrhage. Till now, actually, we don't really have a systemic cause because it was almost all negative. But it was a herpetic with secondary glaucoma with atypical CRVO. This was the diagnosis. But it was improving. You want to find this photo? So this is... no, it's not. By the fundus findings. Yeah, it was started as it was a.
Yeah, but then now what is it? And the real logic is finding a minor, this is reassuring if a patient is not losing a vision. Like it's really good that these are findings.
يعني she was worked up by ID, by hematology, by rheumatology as well were involved.
And now she's not in need
Of treatment.
and no more systemic findings.
No. Yes. Yes. Yeah. Even blood cultures were sent twice, 2 sets of blood cultures, all were negative. Yes. Okay. Okay.
And the comment is, could this be psychogenic? Because when you were presenting this, I was thinking about the psychogenic.
Psychological, you mean?
Something across my mind, it's like psychogenic immunopathy.
No, in the first presentation, it was ophthalmic. It was real that she doesn't see, but at the end, she maybe she liked that she's not seeing. I don't know. Maybe attention. There is psychological issue.
Yes, the question is, could a patient actually not see due to something psychological?
Yeah, there. I believe. Yeah, yeah.
But this is,
Yeah, this is not the okay.
no, this is a logic question. No, when you go to the psychiatric literature, we have one case, 2 cases. We reported in Saudi, a patient with meningitis, and one of the psychiatrists was with us in Corona. And he was bringing to us a market classification for such patients. Some of them, they are doing it subconsciously without clear gain. There's real secondary gain that they are getting. Like a majority of them, they may have a agency gain or something. But this case, we have 2 things, which is the meningitis. You have that to pick it up to save the patient against acid and the toxin circulation. That instead, the diagnosis is not reached.
Dr. Adil, this is the patient. Yeah. Yeah, but I mean, we said this is herpetic uveitis with atypical CRVO.
Yeah, because the patient presented with high IUD, for example, he actually really lack of peaceful cessation at the same side. And nothing else can, put it all together in the same pool, more than it's very weird presentation. Actually, such a picture of like atypical CRVO. Very weird. Do you have any photos for the FFA?
Yes.
For all of us, I know what you negative. So herpetic, you're saying now the suggested scenario, the patient is having herpetic disease, herpetic eye disease, and IOP, and that causes CRVO. Well, this is the scenario. This is the hypothesis of VR, which causes the CRVO and this causes this. But yeah, fair enough. Just want to explain it. Maybe I miss it. This is well taken.
And the other thing which we would not rule out because the patient is malignant, it could have been a form of trauma to the patient, while she would have a common sensation, image at the same time.
And she said also eye exam.
Yeah, so we presented later eye exam, which make our diagnosis different. That wasn't the beginning. There we had the high IUD, the anterior chamber reaction, and this one was fine. You would think that the patient had a very bad trauma. Recently, soon before she presented, a few days before she presented, trauma in the back of our mind, but it wasn't suggestive of anything in the angle.
Doctor, you wanted the FFAs or? So there was a delay in the transient time, as I mentioned earlier. Yeah. 22 seconds.
Very weird. And,
Yeah.
the things that is not showing up here is the periphery of
So if I may answer you, Doctor, the fogging. When we do refraction, you can put a high plus lens, like plus 10 up to 15, and then the vision will be very blurry. Patient, you will, it's to fool the patient. So either they will say we can see now, or after we remove it you can see better, or they will. This is how you test them and try, and you can remove this plus 15 and then put plus 1 or plus 0.5, and then he say, yeah, now I just started seeing, something like that. It's just a fogging technique. This is if someone wants to add. Is that okay?
These are the most difficult cases that we deal with. The meningitis patient, usually they don't admit that they have. Once you know, or they expect that you know they are meningitis, they disappear from the center. Patient, we were admitting them, and we could talk with the psychiatrist to come and just counsel the moment that he knows he's a psychiatrist, he sign against me that tries to disappear.
السلام عليكم ورحمة الله وبركاته. محمد الجديع, fourth year resident. I will present today a short case from National Guard Hospital supervised by Dr. Adil Haidan. We'll talk about the initial presentation of the patient and how the patient is worsening and deteriorate even with the optimal management. Then we'll give a short talk about the disease and the recent articles and management. So our patient, she's 56 years old, a female, known case of rheumatoid arthritis. In the first visit, patient seen in the rheumatology clinic. The patient was in methotrexate, hydroxychloroquine, sulfasalazine, and oral steroid. And at that visit, patient was complaining of pain in the small joints. At that time, they diagnosed as synovitis. They stopped the sulfasalazine and they started atracibs and increased the dose of the methotrexate to 12 milligram. Patient was stable for 11 months with these medications. After that, patient she presented to the ophthalmology clinic complaining of right eye pain and redness. Diagnosed at that time as anterior nodular scleritis in the right eye, and the patient she did not reach the therapeutic window, so advised to hold the Intracept and to start him على infliximab. After the second dose of infliximab, patient symptomatically improved, and there is early signs of scleromalacia purpura. Lab done for the patient to rule out other cause. In the next visit, patient come again complaining of pain and redness with the vision in the right eye 2022, and in the left eye 2020. And there is in the right eye there is inferior tumoral nodular scleritis with a persistent inflammation, with a clear cornea and a quiet anterior chamber, with normal fundi. A B scan done for the patient which showed there is elevated dome-shaped lesion with a low reflectivity. At that time was the impression that patient have scleritis with TRD versus mass. And this is the B scan that's showing you the elevated dome lesion in the fundi. So the plan at that time. Okay. So at that time, it was the plan to keep the patient on the same medication and to take a vitreoretinal consultant opinion. So the patient seen by vitreoretinal consultant, and he described the lesion as he found a small lesion inferior to the inferior arcuate vessels, and according to him, this is not related to the painful scleritis, and from point of him, there is no current intervention. We keep the same management of the scleritis, and he advised to do FFA and MRI of the orbit with regularly doing B scan for the patient. In the next visit, patient after the third dose of the infliximab with the stable vision, less scleral edema and injection. At that time, patient started على topical Pred 40. Then 3 months after, patient coming to the clinic complaining of relapse of the pain with injections. Coming to the ER, not to the clinic. Seen by the general ER physician, and they started على non-steroidal anti-inflammatory medication at that time. 3 months after, patient she missed 2 doses of infliximab because the patient she have abdominal abscess. Then the patient coming to the ophthalmology clinic complaining of a drop of vision. At that time, vision was count and finger, comparing to the 4 months before the 4 months visit before, it was 2020. So in the examination, there is increase in the size of the necrotizing scleritis with large KB with a +3 anterior chamber reaction with severe vitritis, and there is occlusive retinal detachment reaching the optic nerve. And there is also increasing in the intraocular mass that we mentioned before. The impression at that time was patient have severe fulminant scleritis versus Mescal syndrome. The plan at that time was this is the B scan at that time, which showed there is increase in the size of the tumor. So it was the plan to refer the patient to ocular oncologist to take his opinion regarding this tumor. The patient seen in another hospital to rule out a primary tumor and secondary metastasis, intraocular tumor rolled out, and the patient given transseptal Kinkort in that institute. Patient improve, vision become 20 over 135, vitreous become more clear, but still there is occlusive retinal detachment. Then, as the patient has failed the infliximab, the plan was to shift the patient to adalimumab 40 mg 2 weekly and increase the dose of methotrexate to 15 mg weekly. As I mentioned, with the stable vision, 20 over 135, the nodular scleritis become less in size and less in inflammation, and the signs of scleromalacia it's appearing. Impression in this visit, significant improvement, and with the patient on methotrexate and adalimumab. In the next visit, patient come again complaining of relapsing of the redness and pain. At that time, impression was patient have failed infliximab and adalimumab, so the next we'll start the patient on rituximab injection. Patient seen 2 months after with the pain, and visual acuity was count and finger near face with the scleral thinning and the +3 congestion. Also, there is inferior corneal neovascularization with decrease of the sensation with the +2 cells. At this time, suspicion of herpetic it is appear in the to us. So we started على patients on control by rituximab, and we cannot rule the herpetic disease. So we started على topical acyclovir. Patient given appointment after 1 week, but the patient she did not show up. In the last visit, 3 months after, patient coming to the clinic with the +4 congestion, shallow. The IC become shallow because the significant cataract that patient developed. The impression at that time, patient have prethysical eye. The scleral biopsy offered to the patient, but she refused. 6 months after, patient with in the next follow-up, coming with the same visual acuity, hand motion, with the conjunctival congestion and with nodular swelling, and there is scleral thinning and uveal show. The plan was at the time patient is stable, so we'll keep her على الهيوميرال for a few years to prevent the sequelae and the other eye involvement. This is the anterior segment photo of the right eye showing the nodular scleritis and scleral thinning with the uveal show. So this is a case that's showing some patients they will worsening and deteriorate even with the maximal medication that you can use for the patient. So just only rheumatoid arthritis.
What diagnosed?
Yeah, diagnosed and she was mentioned.
Yeah. Did they do workup for regular diagnosis?
Yes. Yes.
Well, almost similar case. He's fine. And was struggled. Then gives diagnosis. Regular diagnosis. They went through this work to what I showed you in this one, I presented almost the same with the scleritis, lesions, like a granuloma in the back of the eye, progressive in spite of treatment. These are one of the things that when you were presenting it hit to my mind. If they did the workup, can't do anything more. Sometimes you need to do a biopsy. The workup that include biopsy not from the eye, from the system. The patient that we did, they took kidney biopsy and tend to be positive. أعتقد that in your case, it's not purely ophthalmic case. It's mostly a systemic case that they need the people. The other eye has nothing.
Yeah.
Nothing. No history.
The thing that this case was presented is because the patient missed one dose of infliximab. She was a bit controlled even though, and she missed it because of the abscesses she developed, or the lung infection,
Abdomen.
possibly the lung infection.
I think abdomen
Abscesses. So she opted and she decided to wait until the appointment. I was very surprised when she came on the appointment saying I have a drop of vision from 20/22.5 till almost hand motion. Although my clinic is always open for the uveitis and scleritis patient to come anytime to my clinic. You see how I believe she was compliant. I even gave my mobile to them to call me in case of anything. Her son didn't even call me on my phone. No, they are not really educated the way I presume. I can tell from such a scenario how aggressive scleritis is, and whatever you put on those patients, it can be very stubborn, and we have such a very failure of everything that we provide to the patient. طبعا one of the things I possibly believe of it is the transeptal triamcinolone acetinoid injection in nodular scleritis is possibly not the best thing to be given to the patient, and most likely make the scenario get into worse. You give a chance for her autoimmune to flare up with missing one dose of the biological agent.
Rituximab, how many given time? Once? The rituximab, you said it was given to her?
Yeah.
Once?
No, she was not.
Usually rituximab is doses that is given as induction, then they give it for spacing. It's not like infliximab or Humira.
Yes, yeah.
They usually take it for a long time.
She took only one side.
Once only.
One side.
Yeah, and
but after this one, she got a bit controlled. The eye is quite all time, and she's receiving the Humira with it.
Yeah.
And I hope the other eye will not be involved. Otherwise, I will push her to you.
And I think اسم الدكتور
محمد.
أنا but just for sake of if you can go, and I know these cases are difficult and challenges. If you can go back and try to trace her file and look for other system دائما الحالات هذه we get involved في ophthalmology بعد ما تكون متأخرة already. And if you go back to her medical file and dig all the investigations and see what other investigations that done and was not done, and based on what thing that you will work on. And sometimes you will be amazed, خاصة with the chronic cases, they will go to multiple consultants and they will do something and they will base their diagnosis in previous labs or previous impressions. فأعتقد أنه these cases need to be looked at back.
I cannot disagree, but in the same time, if we imagine that the patient is Wegener, for instance, or any other, it's autoimmune disease. The patient received already the maximum tolerated medication the patient can receive as immunosuppressive. So we agree that possibly the pathology is different, but the management almost pull in the immunosuppressive treatment.
You need to, the treatment usually in Wegener, we discussed this a while ago. Wegener is one of the most severe diseases to control.
Yeah, I agree with you. I have so far 3 Wegeners that I have in my clinic. I was so lucky to control 2 of them, and one of them is missing the appointments, unfortunately. Well, the patient, we reached to cyclophosphamide and it wasn't controlled. It wasn't controlled. When we shift the patient to the biological agent, the patient was following up with me for 4 years, and she was under quite examination every time she presented to my clinic. No, infliximab. Yeah, at that time the era of rituximab was not available. This was like possibly 10 years ago.
Thank you for presenting.
Assalamu alaikum. So I'll present the last case for today. Quite simple and straightforward in comparison to the other cases. So I'm Mishal Khayal, first of all, 30 years resident. So our case, he's a 34-year-old Filipino man that was complaining of bilateral blurry vision for a few days. He was seen at the ophthalmology clinic. Later on, we heard that the patient passed away 6 months later when he returned back to his home country. So let's see what was the case. So when the patient presented to the clinic, he was having very poor vision in both eyes. IEP was within normal, extraocular muscle motility within normal, external exam was within normal, anterior segment or within normal exam. Dilated fundus exam showed this picture that was similar in both eyes. Intraretinal hemorrhages, grade 4 disc edema with macular exudates, star-shaped macular exudates. So I bet you all know what's this. So we asked the nurse to take the blood pressure. It was very high, 210 over 140 millimercury. So this patient had hypertensive emergency with retinopathy. So hypertensive retinopathy is our case for today. Saudi health survey conducted by the Ministry of Health in 2013 estimated that the prevalence of hypertension among the Saudis to be 15%. 57% of them were underdiagnosed. Stages, we all know the pre-hypertension, stage 1 hypertension, and stage 2 with the different and blood pressure readings, and the malignant hypertension, which is defined as the presentation of acute very high blood pressure with multi-organ damage. Stage 3 or 4 retinopathy is common in this group. It is considered to be as hypertensive emergency and should be treated in the ICU, followed by oral therapy in the general floor. Ocular effects of hypertension can be observed in the retina and the choroid and the optic nerve. Systemic diastolic blood pressure affects the eye more than the systolic. Predisposing factors, the duration of the hypertension, severity of dyslipidemia, advancing age, and smoking. Classification, we can classify the hypertensive retinopathy as grade 0, 1, 2, 3, and 4. Multiple classification systems are there. The first one is the modified Shea classification. Grade 1 defined as barely detectable arterial narrowing. 2, obvious arterial narrowing with focal irregularities. 3, grade 2 plus retinal hemorrhages or exudates. Grade 4 is grade 3 plus disc swellings. The other classification is almost similar. We can see that grade 1 and 2 are present in chronic changes or represent chronic changes, and grade 3 or 4 indicates acute retinal vascular decompensation. So this is the different signs of retinopathy. Here we can see in the first picture the arteriolar attenuation or narrowing. Grade 2, we can see the AV nipping in the second picture. Grade 3, we can see the copper wiring of arteries. And 4, the silver wiring of arteries. Findings, retinopathy, acute findings, we can see the focal intraretinal prearterial transudates or the cotton wool spots, and chronic changes could be microaneurysms, erymas, blood hemorrhages, lipid exudates, venous bleeding, and could be MVEs. Some other findings, we can see here the Salus sign, Bonnet sign, and the gun sign in grade 2, 3, and 3 as well. Choroidopathy, we can see 2 different signs in choroidopathy: Elshing spots, which is round yellow acute small focal choroidal infarcts seen in grade 3 and 4, and Siegrist streaks, which are flicks around the choroidal vessels. In severe cases, we can see focal RP detachments or extensive exudative RD. Here are the Elshing spots and the Siegrist streaks. Optic neuropathy, we can see linear peripapillary flame-shaped hemorrhages, blurring of disc margin, edema, secondary retinal venous stasis, and macular exudates. Complications, we could have central retinal occlusion or vein occlusion, as we know, a branch retinal artery or vein occlusion, retinal macroaneurysms, anterior ischemic optic neuropathy or non-ischemic cranial pulses, and other complications. Management, we should treat the underlying cause, of course, and treat the blood pressure. This causes the resolution of the fundus abnormalities over a period of weeks to months in eyes with grade 3 to 4 changes, but often does not affect the changes seen in grade 1 and 2. Oral nifedine for the treatment of acute grade 4 hypertensive retinopathy is recommended. Laser is still controversial, as well as intravitreal anti-VEGF. That could stabilize the walls of the retinal vessels with grade 3 and 4, but it's not needed at the time being. So prognosis, vision, typically unaffected in grade 1 and 2, may be mildly affected in 3, markedly decreased in grade 4, as our patient, due to retinal edema, hard exudates in the central macula, or the presence of serous detachment. Mortality rate in grade 4 reaches up to 94% in 18 months. In conclusion, recognition of the posterior segment vascular changes by the ophthalmologist may prompt the initial diagnosis of hypertension and alert the patient to potential complications from this condition. Thank you. So our patient obviously did not take his medication when he went back to his home country. Any questions? Thank you.
الساعة 3 المفروض everybody is available.
وين ماجد؟ Can somebody call الأخ ماجد? Can somebody call الأخ ماجد? إلى الآن ما جاء. طيب. Can you detach please? Okay, good. Can you be around please? Or you can just stay with us for a while please. That's weird. دكتور حمود, when you are ready tell me. ترى حتى أنا بعد ما جهزت إلى الآن لأنه أنا ما كنت أدري إنه مازن هو اللي المفروض يقدم الكويز.